Topics for today include extractions, anchorage, and treatment of Class 1 malocclusion. Subtitle for extractions could be extractions for orthodontic purposes. We're not talking about extractions of carious teeth or extractions of impacted wisdom teeth. Dr. Engel believed that every individual has the potential to have 32 teeth in normal or ideal occlusion. Dr. Engel had a non-extraction philosophy. He's a non-extractionist. He believed that if his students used his techniques and established a correct occlusion, there would be a stable result. If there was relapse, it was the fault of the orthodontist, not theory. So he's saying, I'm right, you're wrong. Dr. Engel was a very brilliant clinician. We've already seen that he's responsible for the Engel classification of malocclusion, but he didn't get the non-extraction philosophy quite right, that you don't need to extract teeth at all. I think the consensus today is that if you start approaching 5, 6, or more millimeters of crowding, especially in the lower arch, you're headed in the direction, or you are extracting teeth. You are extracting most likely bicuspids. Serial extraction was developed in Europe in the 1930s as a simple method, so-called simple method, of dealing with severe crowding problems, sort of a socialized medicine approach. Common eruption sequence in the permanent dentition in the maxillary arch is the first bicuspid erupts first, second bicuspid, and then the canine. In the mandibular arch, it's canine, then first bicuspid, then second bicuspid. The purpose of serial extraction is to disrupt the usual eruption sequence. We want the first bicuspids to erupt before canines in the mandibular arch. We start the extraction procedure early in the mixed dentition to avoid crowding in the permanent dentition. This facilitates fixed appliance therapy later in the permanent dentition. Contraindications are skeletal discrepancies, deep overbites. You need assistance of maxillary Hawley with a bite plate. You don't want to use serial extraction in patients with hypo or hypertonicity of the soft tissue, and caution using them when there's habits present. The clinical approach is that you first observe mandibular anterior crowding, a lot of crowding. The laterals are lingually locked, rotated. You take records. We want to find 10 millimeters of crowding, at least. If you do a space analysis and you find this degree of crowding, then we can begin the extraction procedure. Now, serial extraction isn't used all over the world routinely. I seldom use it, but there are pockets of its use in the States and around the world. And so we need to talk about it for that reason, and for the reason that these kind of questions often show up in tests and boards. The sequence is that first we extract all deciduous canines. We have a space. The crowded anterior teeth will fall back into that space. This eases the anterior crowding and promotes hygiene, not always ideal. So we're doing serial extraction because we're seeing a lot of crowding present, and the child is having a hard time keeping things clean, and we want to prevent decalcification and possible caries later on. It's a self-alignment process. Then we extract the deciduous first molars 6 to 12 months before normal exfoliation. That will increase the speed of the first bicuspid eruption because we're doing it at the right time, more than half root development, as we've talked about in a previous lecture. Now we have space for the cuspids to erupt and to fall back in, and for the anteriors, the incisors, to further uncrowd. Spontaneous space closure occurs. This is the sequence, the summary, and the end result is less crowding, but not an ideal occlusion. But again, the main purpose was to uncrowd the lower anteriors to promote hygiene. Benefits: naturally induced alignment of severely crowded anterior teeth, leading to improved periodontal health, improved cosmetics, better psychological state. Kids can smile again. It facilitates the fixed appliance workload and less damage. Damage being, again, the white spots, decalcification, possible caries, and also perhaps less time in braces to minimize root resorption. Anchorage. Anchorage is a tug of war. Both sides move. Winning side moves a little. Losing side moves a great deal. Almost 20 years ago, TADs were introduced, and TADs don't move. They're the ultimate anchor. They're not used universally. I don't use them on every patient, only use them on selected patients, but they're available and greatly assists our tug-of-war battle. Success in orthodontic treatment depends on proper space management of anchorage control, anchorage considerations,